Welcome to the kanski lecture series, and this is the chapter 9, Episclera and Sclera. So, as you know, that cornea forms the 1/6 part of the outer coat of the eyeball, whereas the sclera forms the other 5/6 part of the outer coat of the eyeball. So, let's get started. You know what is sclera? Sclera is basically this is cornea, and the whitish portion that you see around the eye is sclera. The scleral stroma is composed of collagen bundles of varying size and shape that are not uniformly oriented as in cornea and so are not transparent. So cornea is transparent, whereas the sclera is white in color. So it is whitish in color. It is also composed of the collagen fibers, but the collagen fibers are of various sizes and shape and are not oriented parallel to each other, so they are not transparent. The inner layer of sclera, the lamina fusca, blends with the uveal tract. Interiorly, the episclera consists of the connective tissue layer between the superficial scleral stroma and the tenon's capsule. There are three pre-equatorial vascular layers. So, the sclera, basically, this is sclera, and there is a tenon capsule over the sclera, and there is a conjunctiva over them. So, tenon, conjunctiva, tenon, and then sclera. So the episclera is basically between the superficial stroma and the tenon capsule is called episclera. There are three pre-equatorial vascular layers. Conjunctival vessels are the most superficial. Arteries are tortuous and veins straight. So there are different vessels. There are conjunctival vessels, there are superficial episcleral plexus and the deep vascular plexus. So due to their orientation you differentiate them, and you can differentiate also depending if there is a congestion of some certain kinds of vessels, then you can determine with the pharmacological drops phenylephrine that it is episcleral or scleral or conjunctival. So conjunctival vessels are superficial and their arteries are tortuous and veins are straight. Superficial episcleral plexus. Superficial episcleral plexus vessels are straight with a radial configuration. In episcleritis, maximal congestion occur at this level. Topical phenylephrine 2.5% will also constrict the conjunctival and 10% also the superficial episcleral vessels. Deep vascular plexus lies in the superficial part of the sclera and show maximum congestion in scleritis. A purplish hue best seen in daylight is characteristic. So whenever there is a conjunctival congestion, so you do not know that either it is a conjunctival congestion or episcleral congestion, then you can use topical phenylephrine 2.5%. If the vessel constrict, it means that it was a conjunctival congestion. But if it does not constrict, it means the episcleral congestion. But the 10% phenylephrine will also constrict the episcleral plexus. Episcleritis. So basically, scleritis and episcleritis is usually an immune-mediated diseases that occur in the case where there is an immunological problem, systemic immunological problem, but can occur with the infections as well. So episcleritis is basically the episclera is becoming inflamed. Episcleritis is a common, usually idiopathic, benign, recurrent, and frequently bilateral condition. So it is, you don't know about the cause. It is benign and it can reoccur, and it is frequently bilateral. Females may be affected more commonly than males, except possibly in children, in whom episcleritis is rare. The average patient is middle-aged. It is typically self-limiting and tends to last from a few days up to 3 weeks, but rarely longer. So episcleritis is a recurring disease, but it is also self-limiting as well. Means that it can resolve on its own without any treatment as well. Associated diseases in either ocular, for example, dry eye, rosacea, contact lens wear, or systemic Collagen vascular disease disorders such as rheumatoid arthritis, herpes zoster ophthalmicus, gout, Crohn disease, and others have been identified in the tertiary referral centers. Infectious causes are very rare, but a wide range has been reported. Investigation of recurrent diseases of scleritis. See later. Acute episcleritis is common, usually idiopathic, and has a good visual prognosis. So that these are infectious causes is very rare in the case of Episclera or Sclera. So you can see figure 9.1 in it showing A is showing the episcleritis with maximum vascular congestion of the superficial episcleral plexus, and B is showing the scleritis with the scleral thickening and maximum congestion of the deep vascular plexus. So there are two types of episcleritis. One is simple and other is nodular. So nodular is basically there is a nodule formation in the episclera. And diffuse is when the diffuse is involved, and it is also it is like diffuse. Simple is also diffuse and sectoral. Simple and nodular. Nodular is further divided into diffuse and sectoral. Simple episcleritis account for 75% of the cases. It tend to recur, 60% decreasing in frequency with time. Features often peak within 24 hours, gradually fading over the next few days. This symptoms discomfort ranges from absent up to 50% to moderate. Grittiness is common and photophobia may occur. Signs. More than half of the cases are simultaneously bilateral. Visual acuity is normal. Redness may be sectoral, two-thirds or diffuse. Often it has an interpalpebral distribution in a triangle configuration with the base at the limbus. Chemosis, ocular hypertension, anti-uveitis, and keratitis are all rare. So basically, as I told you, episcleritis is a bilateral condition, self-limiting, but it can have a multiple recurrences. So it is usually occur in the anterior two-third. Look, here it is simple episcleritis. This is A is showing the sectoral involvement of the episclera, and B is showing the diffuse involvement of the episclera. And its base it at the limbus. So you will see like this. So this is an eye. The base is at the limbus. Treatment, if mild, no treatment is required. Cold compresses or refrigerated artificial tears may be helpful. A weak topical steroid 4 times daily for 1 to 2 weeks is usually sufficient, though occasionally more intensive instillation is needed initially, or more potent preparation can be used with rapid tapering. A topical non-steroidal anti-inflammatory NSAID is an alternative, though may be less effective. An oral NSAID is occasionally required, for example, ibuprofen 200 milligrams 3 times daily, or occasionally a more potent agent such as indomethacin. So basically you have to treat with the cold compressing, but sometimes you can do topical NSAIDs or you can use topical steroid, but depend on the severity of the disease. Nodular episcleritis. Nodular episcleritis. So as I told you, it is this involvement of the sclera but in a nodular fashion. Nodular episcleritis also tend to affect female more than males, but has a less acute onset and a more prolonged course than the simple variant. So it has a less acute onset but more prolonged case. Symptoms is a red eye is typically first noted on waking. Over the next 2 to 3 days, the area of redness enlarges and become more uncomfortable. So how does a patient present? A patient when wake up in the morning, he says, my eye is red, and the redness enlarges in the next 2 to 3 days. Signs. Attack usually clear without treatment but tend to last longer than a simple episcleritis. So it has a longer duration of disease process. A tender red vascular nodule, almost always within the interpalpebral fissure, occasionally more than one focus, is present. A slit lamp section shows an underlying flat anterior scleral surface indicating the absence of scleritis. Intraocular pressure is occasionally elevated. An anterior chamber action may be present but is uncommon. 10%. After several episodes, inflamed vessels may become permanently dilated. It is important to exclude other causes of a nodule such as phylacterosis. A phylactery is within rather than beneath the conjunctiva or a conjunctival granuloma. Treatment is similar to that of an episcleritis. So you can see here as a nodular episcleritis, and this is a slit lamp picture showing that interior sclera is flattened whereas the nodule is raised. So you can differentiate it with the phylactery, which is within the conjunctiva, and episclera nodule is beneath the conjunctiva. And there can be interior uveitis, but these are all rare features of it. So that's it for the Episclera and Sclera part 1. We'll see you in the next lecture.